So the title of my talk is the National Prevention Strategy. You'll see that I live a tangled life in the sense that I've been doing work to support the Department of Health in the development of this strategy through my employment with the Sachs Institute, which ended a couple of weeks ago. And I've recently been appointed and taken up the role of Executive Director with Sydney Health Partners. As the work that I've done has been largely through the Sachs Institute, I've stuck with the Sachs Institute slides, but I have to issue this modest warning that whatever I have to say this morning are my views. I certainly can't represent Sachs interest. The Sachs Institute, I don't, in this presentation, represent Sydney Health Partners, and I absolutely and most certainly don't represent the views of the Australian government. So what I'm going to try to do in this introduction, four things basically. I want to take a look back. I was interested in our international keynote speaker yesterday, used a wonderful quote from an ice hockey player who said you should always follow where the puck is going, not where it's been. Actually, I would just offer a counter view is that we tend often to forget the lessons of the past in public health and find, as we have on an occasion like this, we have to rediscover traditional public health and keep with it. So there's a bit of looking back, a bit of looking forward. I want to offer some observations on the National Preventive Health Strategy, although I should say I can't stand the term preventive health. I don't know what it means really. I want to highlight within the context of our meeting overall some issues emerging with specific reference to research priorities in prevention and what's referred to as precision prevention, and then finish in some way by establishing an agenda for our panel discussion to follow. What I will do during the course of my presentation is I've dropped in a couple of provocation slides that are intended to encourage people to comment and ask questions. And I'd encourage those who are listening in today to participate in the process. It can be, those questions can emerge either at the end of my presentation or alternatively we can use them during our panel discussion that follows. I'm not going to spend long in describing the problems. I think they're well known, and we have this fantastic organisation called the Australian Institute for Health and Welfare, which has a marvellous website for those of you who want to continue to examine the nature of the problems that face us, where prevention has a role in tackling those problems. But I have got one or two slides to orient us. The first is this wonderful slide, and I apologize if it's not clear on the screen, but I could just encourage you to go to the website and have a play with it. It's interactive, but it just describes what are the major contributors to the burden of disease in Australia and the extent to which they're amenable to change and changes that have occurred over the past decade or more, 20 years or so. And they show a picture that I think everybody will be familiar with, that coronary heart disease, for example, still remains the number one contributor to burden of disease in Australia, but that contribution has reduced significantly because of prevention and because, of course, of advances in diagnosis and treatment over the past 20 years. And all of these changes they're not all about prevention, they're not all about treatment, they're always about a combination of both. But some observations to make: that there have been some encouraging reductions in the past 20 years in the impact of coronary heart disease and stroke, in lung, breast and bowel cancer, and in road traffic injury. And as some things improve, others emerge, of course. And during the same period of time, the contribution of dementia, musculoskeletal disease, chronic kidney disease, suicide and self-harm have all emerged as being more important as contributors to the burden of disease. The next question is, of course, so what is it that's driving the burden of disease. What sits beneath that picture? And what I've said here, it does depend on how you ask the question. And so typically, we tend to focus on individuals and their characteristics, their behaviors and lifestyles and so on. And again, I can encourage you to go to the AAHW website if you're interested in exploring this a bit more. But again, those factors that come out as individual risks, most profoundly are those that we've known about for some time. So tobacco use, overweight and obesity has emerged profoundly in the last couple of decades as a major driver of the burden of disease in Australia, combined with other dietary risks. And then the list are all personal characteristics that you'll be familiar with: high blood pressure, high blood plasma glucose, alcohol use, high cholesterol, illicit drug use, and so on, running right down to the bottom to unsafe sex. But it does depend on how you ask the question. If you ask the question in a different way, what are the causes of the causes, and why do we observe such profound social distribution of these risk factors in the population, you start to get a different type of answer. We know that the disability adjusted life years rate in the lowest socioeconomic groups was 1.5 times as high as in the highest group. And as it says in this slide taken directly from the AAHW website, 32% of the disability adjusted life years in the lowest socioeconomic groups could have been avoided if their life experience had been at the same rate as those in the highest group. So these underlying social factors that are the causes of the causes. And again, some of you may be more or less familiar with the work that WHO has led on this, and in particular, the Commission on the Social Determinants of Health, which included one of our own fellows, Fran Baum, led by Sir Michael Marmot, I should immediately say, an alumnus of the University of Sydney. And this, I think, has provided a really important benchmark for us to consider what's driving the burden of disease in our population. It's not just the choices that people make for themselves, but the constraints on those choices that are provided within, that are a consequence of the environment in which they live and work. Early life experiences, financial and social exclusion, employment, housing, the built environment, political access and participation are all factors that are driving the observable social distribution of these individual risks. And we know, as a matter of fact, that those with the most resources, financial, social and political resources, have far greater choices in their life, more options and greater resilience to shocks such as that we're existing at the moment. Now, I should say, we've always known this in public health, but occasionally we forget, and we become very focused on individuals and their individual risk, as opposed to looking to balance out consideration both of what individuals do for themselves and what society creates for them as a set of choices. And so my first provocation to get people talking is, so when we're thinking about a national response to this in Australia, where would the focus be? Should it be mostly on encouraging people to make healthy choices for themselves and their family? Or should we look more to governments and communities to act on the social determinants of health and create healthy options for everyone? Or should it be on tackling existential threats such as climate change and related environmental stewardship? I know that in the feedback that the government's been receiving of late, that there's some concern that that part is missing from consideration of a national prevention strategy at the moment. Of course, the answer is it's not either or these, but the question is for government, what's the balance? So I have to say Australia has a fantastic track record, and this is me looking back now, and there's a terrific publication if you want an advocacy document made available by the Public Health Association of Australia, about the top 10 public health successes of the last 20 years. And I'd certainly encourage you to look at it and to use it as an advocacy tool, which is what it was designed for. I want to pick off 3 case studies for a quick look to see what should we be learning from past success that we should continue to apply as we think about the future. And the first of those is the extraordinary success that Australia has had in tobacco control, both in absolute terms, in seeing an overall reduction in tobacco use, and in relative terms, relative to other countries. And the 2 messages I really want to communicate that we ought to learn from tobacco control in Australia is, firstly, that it's been a comprehensive effort reaching right across government, engaging a whole range of non-government government agencies and non-government organisations, as well as overtly seeking to engage the population at large through effective social marketing and other forms of communication. And the programme itself has consisted of public education, for example, direct support for smokers to quit, regulation of supply, access and promotion of tobacco products, and the use of fiscal measures to simply make it more expensive to be a smoker. And second point, it's been sustained. The success that Australia has had has taken us 50 years. There's no magic bullet here. It's required a comprehensive and sustained effort. I now have another one of those slides that will be incredibly hard to look at on screen, and I just want to leave you with an impression. Firstly, an impression that lasts over 50 years, from the 70s, when early work on tobacco control began in Australia, through to the present day, and the current draft national tobacco strategy that's intended to point to the elimination of tobacco use in Australia long term. The different colours on this chart represent different types of strategy, including cessation support, the packaging and health warnings, smoking regulation, the use of legislation and regulation, and industry regulation as well. And the picture it's intended to paint is this sustained and comprehensive approach to tobacco control. Now, one of the joys I've had with the checkered career that I've enjoyed is that I had a period in government, as Tony has mentioned. I was the head of public health during the Blair era in the British government, and had an opportunity to try to advance tobacco control policy in the UK. And one of the reasons why I was engaged by the government was to try to bring more evidence to bear on public health policy decision-making in the UK at that time. And my next slide is a taster of one of the dilemmas that we often face in the context of bringing science to bear on policy decisions in public health. It's actually difficult to know what works. I'm not aware of any randomized trials, for example, of the control of organized crime to reduce tobacco reduce tobacco smuggling in the UK, and wasn't really able to offer much evidence-based advice on what was a pretty obvious thing that needed doing. There's not really the type of evidence that we might typically seek for the effectiveness of fiscal measures to reduce tobacco use in the long term. We know that in the short term there's often an impact, but we don't know what the long term is, and it's really hard to set up the type of conventional evaluative work that we might do in other aspects of health and medicine. But we try to make systematic observations in order to get a better long-term picture, and this is sort of where you end up. You see this long-term decline in tobacco use in Australia over, in this case, showing about a 25-year period. You can align the different elements of Australia's tobacco control strategy with change over time, but it becomes really hard to prosecute the case that this is solid evidence to support the types of things that we know and understand are likely to be successful. And it's one of the dilemmas I'd like to pick up in our discussion as my talk progresses and we move into a panel discussion later. How do we know what works in prevention so that we can ensure that the minister and the department get the best available scientific advice to drive policy decisions going forward? A couple of final comments on tobacco control. What is outstanding and what looks good for the future has been a sustained reduction in smoking among high school students. You can see here that we're really genuinely heading towards zero with high school students, particularly the younger high school students, from a position where there were 30% of kids just 25 years ago, aged 16 and 17, who would describe themselves as committed smokers, down to close to 10%. Now, these are real signs of progress long-term in Australia. Having said that, there is a typical warning sign that I will consistently come back to, and that is that so far so good, but there are some significant social, economic and cultural communities that at the moment remain significantly untouched. One of the dilemmas we have typically in prevention is what works for the majority in the population may not work so well with identifiable social groups in the population. And one of the long-term effects of this is that it can actually exacerbate existing inequalities, because we make great progress with one segment of the population and we leave another segment further behind. And that's one of the dilemmas that I think one of the challenges I think we're faced with in tobacco control and in a number of other key areas in prevention. As we make progress as a whole population, we actually create a situation where we're exacerbating already existing inequalities in health. Second case study I want to, so messages there are about comprehensive and sustained interventions are what make a difference. There's no quick fix in prevention. Second example I want to look at is Australia's response to HIV and AIDS, which again, I think internationally is seen as being exemplary, and the data speak for themselves in terms of long-term trends in HIV infections in Australia. There have been a number of really helpful reviews of, so what did we learn from 20 years of tackling HIV in Australia, about how you go about tackling an event, a public health event of this type, and what is it from that learning that might have wider application. I particularly wanted to both acknowledge these source documents and also try gamely to summarize what they have to say. Firstly, a couple of quotes from these source documents. First of all, observation that our response in Australia saw one of the most rapid and sustained changes in community behaviour in public health history. Other than the types of responses that we see to pandemics, such that we've observed in the last 6 months in Australia, Australia's response to HIV was extraordinary in that regard. Second, really critical message in this particular instance, it had to be and was very successfully a grassroots up movement rather than a rather more centrally controlled approach to managing change, which has probably been the correct characteristic of our response to this pandemic. And we also benefited enormously from well-funded, bipartisan, collaborative response and some serious political leadership at the time that it was required. And again, there's some messaging from that might need to pass across in our current response to the pandemic, that a bipartisan approach, a sustained bipartisan approach, is going to be really important. And as the pressures emerge in our political system in Australia, it's really important from a public health point of view we keep emphasising the importance of a bipartisan response to this. I don't know if you've caught up with the news overnight, but in the UK there are really significant fractures appearing in the political landscape, and I can't bring myself to mention the US and the way in which those political fractures have impacted on the health of the public in the US. What worked, or I should say, how did it work? Really effective public education, but not so much of the conventional broad spectrum social media communication, much more targeted grassroots-based communication, peer-based, direct, explicit messaging that's normally difficult for governments to get engaged in. Of course, we're all familiar in Australia with the Grim Reaper public education, high impact public education, but behind that was a phenomenal effort in reaching some of the most high-risk groups. Secondly, really effective community engagement of priority populations and groups that were typically marginalized and often harder to reach. And this became a fundamental part of our response. Unprecedented partnerships between the government and civil society organizations, again, that I think really very important learning from that. And also, I think for the first time in Australia's history, a real public airing of the concept of harm minimization, things that you wouldn't typically do, but you need to do in order to reduce harm in a population. And that's a discussion that continues as a part of the prevention policy making from this time. So some really important headline messages. There are also some other very important messages in there. Very quick response from the health system, some underpinning legislation and regulation, the political consensus that I spoke about earlier, and progressively really strong science and social research that actually drove the response along. So again, some very important lessons from that. Again, for those of you interested, our current 8th national strategy is incredibly ambitious and looks to a future that is free of HIV, and we're able to be that ambitious as we are in tobacco on the basis of this comprehensive and sustained approach to tackling the problem. The last case study I want to draw upon to consider the lessons that we can learn really firstly picks off correctly the fact that Public Health Association focus on immunisation as a success story in Australia, and they particularly focus on the impact of a rotavirus vaccine introduced in 2007. I wanted to briefly touch upon another great Australian success story, the HPV vaccination, of course, and the impact that this has had nationally and internationally across the world. I don't have time to get into the detail of this, but there's an absolutely fantastic report from the National Centre for Immunisation Research and Surveillance that provides great data and good information on just how successfully this program was introduced. But there were, and its long-term success in some subsequent published papers. There were some very important lessons learned, though, about the introduction of a vaccine. And the reason I've picked this is because we will have to learn some of these lessons really fast, should it be the case that we get a vaccine that we want to introduce in Australia in relation to the current pandemic. The implementation of the HPV vaccination program was generally considered a great success, but there were a number of glitches that we could anticipate and plan for going forward. Firstly, from the point of view of those who were responsible for administering the vaccine, there was a sense that there was a very short time period to organise, in this case, 3 doses for a large cohort, even though they're a highly accessible population through schools. In this case, there were some concerns about the fact that the information resources needed to support both those providing the vaccine and those receiving it and their families were late in coming. And this created some space for community concerns to emerge about vaccine safety and potential adverse events. I'm not recommending it, but if you go online, you can find these really emotive anti-vaxxer materials. This is one about HPV called Sacrificial Virgins, playing to parental concerns that somehow having this vaccine might promote early sexual debut in adolescent girls. Honestly, the anti-vaxxers don't play by the same rules that we do, and we can reliably expect that they'll be very active as and when a vaccine for COVID emerges. And it's something I know Julie Leask will probably speak to a bit later today. So things that we can learn that have immediate application going forward as we look to the introduction of a vaccine. The extension of the program to adolescent males was easier because of the lessons learned. So what do we learn from that? Creating supply, protecting the supply chain, really important. Engaging health professionals early, communicating effectively, and a really effective public education campaign that anticipates potential concerns, and in particular targets some of the harder to reach populations. We're very fortunate with HPV that we were largely looking to administer this in the first phase through schools and a structured environment. So another one of those provocations, taking away from those lessons. So what should a national prevention strategy look like, focus on? Should it be focusing on better funded prevention services, with our health services taking a much more visible lead in prevention? Should it be more about, based, for example, on the experience with HIV and tobacco control, should it be more about mobilizing non-government organizations and community groups to work directly with communities and individuals? How important is it that we focus our attention on providing accessible, credible, understandable information for individuals to act on? And how important in all of this is the role of government, and not just the health department, but other parts of government in tackling complex problems? Of course, again, this isn't either or. It's all about what should the balance be in a national strategy. So I'll speak briefly, just briefly, because you can engage yourselves in the current process of developing the national prevention strategy. But I just wanted to bring you up to speed if you weren't already. So there has just been I think I would call it the second phase of the consultation on this has just ended, and there will be a third phase based on a draft strategy currently timed for sometime at the end of this year, probably more likely early next year. So plenty of opportunity still to have your say. What I will say is there's been a tremendous amount of effort, significantly, I think, assisted by the Sachs Institute's work in mobilizing what's the best available evidence to inform policy, a whole series of targeted consultations, plus a public consultation with more than 6,000 responses to the public consultation, and a lot of effort to try to bring together within a single strategy what are a whole lot of unconnected and rather disparate other government policies, frameworks, and strategies that have relevance to an overarching national prevention strategy. In fact, at one stage, the last time I looked, we were trying to incorporate elements of 38 other policy areas into a single national prevention strategy, and that takes quite a bit of juggling, I think it's fair to say. I want to share with you, as a matter of fact, how the current aims of the strategy are expressed, and I'd have to say also I'm personally very supportive of this group of 4 aims for a national preventive strategy. Firstly, focused on providing the best start to life. Secondly, adding health to life. So it's not all about life expectancy, it's about the quality of life that you live. Thirdly, overtly addressing inequity in health. And then finally, putting your money where your mouth is, that there's some rebalancing of funding towards prevention. There are a set of current goals. I don't have time really to get into these, but you'll see reflected in these goals a lot of the learning that I've tried to highlight from the case studies that I picked out. The importance of working across different sectors, including and especially across government, that the health service should lead by example, and it should be obvious that the health system places value on prevention and invests in it, that we look to create environments that will support health and support healthy choices for individuals, that there will be mechanisms through which there are obvious ways in which different communities can engage in prevention, particularly by working alongside, through and with civil society and non-government organisations. A real commitment to try to ensure that everyone in the population is as well informed as they can be. They have the options, the knowledge and the skills to make the best decisions about their health and the health of their family. And finally, a sincere commitment, which has been nothing but strengthened by our current experience, to ensure that this is an adaptable strategy, one that's capable of responding to emerging issues and new science. So those are the underlying goals, and you'll see a lot of what I spoke about earlier being transferred as good learning into a national strategy. The really big question at the moment, and the one that I hope we can engage in a bit today, is this sense that we need to create something more of a sustainable, comprehensive national prevention system. And this is the trickiest part, because in a way there's good science to guide the aims and the goals that I've described earlier. We've got good experiences to build on. But looking ahead, what is it, what kind of structure is it that we need in place that will provide a comprehensive and sustained approach to prevention going forward in Australia? And the consultation document canvasses some of the issues around this, including, for example, how do we provide strong leadership and effective governance? What is it that's required to create and sustain the type of partnerships that are valued? What is it that drives action within the health sector in particular, but other sectors also? What is it that we need to do to ensure that the public has access to the information that individual members of the public need at any point in time? And how would we know if we were making progress? And this is subject to quite intense debate at the moment, and now is a really good time for us to engage in that debate. So I've offered another provocation. So what should our national prevention system look like? Is it a service? Are we looking for a service? Are we looking for what I call an enabling mechanism? Are we looking for an established public information source, a coordinating body, a strong technical body? The answer, of course, is the same. It's all of those things. The question is in what combination and with what emphasis. So I want to finish off with a couple of comments that are most definitely off-piste in the sense of my warning at the beginning of this presentation. These are definitely Don Nutbeam's personal views of the world. But given we are the Academy, I wanted to talk a bit about advancing the science of prevention, and I wanted to talk a little bit about what people refer to as precision prevention. In terms of advancing the science of prevention, well, I can't resist, of course, going back a decade to when I was invited to chair for the NHMRC a review of public health research funding in Australia. And I have to say, I read the report for the first time in 10 years, quite recently, and I was rather pleased with myself in the sense that almost all of the conclusions that we made 10 years ago remain really valid today. Actually, there's a lot of public health research going on in Australia. It's not a volume thing, but actually it's really poorly coordinated and often lacking in any kind of strategic focus in terms of meeting public health priorities in Australia. Second point that it makes really strongly is that by any measure you care to use, less than 5% of all funded research in Australia is dedicated to testing and evaluating public health interventions. 95% of the research in Australia in public health helps us to describe and better understand the problem, but isn't actually actively testing solutions. And that balance seems all wrong to me. Thirdly, when we do intervention research, it's almost entirely investigator-led, and it's of the highest quality. The problem is, if I can quote a good colleague of mine, George Davies-Smith, we're providing the perfect answers for the wrong questions. So a lot of what gets funded is very small scale, very, very focused, and not really dealing with the causes of the causes. It might focus, if I could, on a small worksite intervention to encourage activity around the working day. Randomized trial, very impressive methodologically, but it's producing results that really aren't helping us to drive forward on the big picture issues that are needed. It's not providing evidence of the type that's needed to drive forward the full range of the comprehensive response that's required. So we keep answering questions that no one asked, but we do it superbly. And the more positive recommendations, I think, we really saw the need for large-scale, longer-term, nationally strategic research investments. And to be fair, the government have invested in the Australian Prevention Partnership led by Andrew Wilson, and there's great work going on through the partnership in understanding more complex forms of intervention. I'm thinking of work particularly led by people like Penny Hoare and Adrian Bowman, who'll be on our panel later on, that's really helping us to understand a lot better how this occurs. But we're still some way off what I think was envisaged in this report. And then finally, the sense that we need to commit more to research translation. So again, we're doing great research in Australia, but it's not being transferred into public benefit through scaling up and systematic approaches to applying what we're learning from shorter term and small scale activities. And we made a whole host of recommendations. I also read, it took almost 2 years to get a response from the NHMRC, but I also reread the NHMRC response. If you notice the subtle difference between these two slides, one says NHMRC response at the top, and actually all the recommendations were accepted. What I'm finding difficult is observing what happened next, because beyond the Australian Prevention Partnership, it's very difficult to see any adjustment to the patterns of research and research grant giving that have emerged from this era that would reflect an acceptance of the recommendations in that report. So my sense is we've still some way to go, but I offer it up as another provocation that people may have strong views on. The last thing I wanted to just touch on before finishing up is the connection back, if you like, to day one of our meeting yesterday, where I think we had a really inspiring set of presentations about the future of, I've put here the 3 Ps, proactive, predictive, and personalized medicine. Today, I wonder what it means for prevention, proactive, predictive, personalized. And one of the, and I use this word in a positive sense, one of the more provocative explanations of this came in the last year from the Public Health England green paper for the government in the UK on a national prevention strategy for England, where they were really seeking to leverage off emerging science and the emerging capacities within the UK to apply genomics and artificial intelligence to prevention. And these are direct quotes from the document, the idea that the 2020s will be the decade of proactive, predictive, personalised prevention. And it says boldly, the NHS will be there for people even before they're born. And the idea is that people have access to health information far more than they've ever had in the past, and that health interventions all become highly personalised. The critical thing is that people are no longer passive recipients of care. They're co-creators. I love this language, co-creator. And it really is stimulating and quite visionary, and nearly caused me to have a heart attack, I should add, and I'll explain why in a moment. But it's an inspiring vision of the future, using the science of today to drive the future of prevention. And I'd be interested in people's reactions to that. I have to say I have some reservations about it, and I'm not going to keep quoting from the report. If you're interested, it's still available online to look at. Rather like the Australian strategy, it's sort of a little bit on hold at the moment, especially as Public Health England, who authored it, are being closed down at the present moment. But it's glowing. This information can empower us in unimaginable ways. We're entering a new era of evidence-based self-care, personalised health advice, bespoke services, smartphone apps, text messaging. The whole works, basically. You know, I'm sure. So 2 words of caution that I want to bring to that, based on our history as much as the excitement of the future. The first thing to say, honestly, is there is almost limitless access to information today. Genuinely, there's an estimated 400,000 health-related apps available to download to your phone today, and millions of web pages. I mean, literally, you do the Google search, you see the numbers, they're incredible. The point is, these are largely unregulated, in many cases strongly commercially connected, and in very, very few cases have they ever been subjected to any evaluation. The truth of the matter is, even those sites that we might consider to be trustworthy sources of information, websites, apps, those provided by governments and leading non-government organisations, when examined, often require a reading age that means that you need a PhD or at least a university education. And it's often the case that these sites are accessible only to the already most advantaged parts of the population, even those we consider to be good ones, and from trustworthy sources. So this overwhelming choice means that we have to help people develop what we call digital health literacy, helping people to identify what's credible, what's usable for them. And we also need to turn it around. Governments and civil society have a really important role in contributing more systematically to ensure access to trustworthy information. And by accessibility, I mean that it requires, a below average reading age and is created in a way that actually supports people rather than further disadvantages them. The second is a slightly more insidious reaction I had to these elements in the English strategy, in that throughout the document, it focused attention all the time on the choices that people have to make for themselves. I chose my words of a brave new world of public health rather deliberately here, but I did write an editorial commenting on this where, even though the consultation is closed, I hope that the feedback they received reminded them of the history of public health and the importance of seeking to balance out the attention that we might give to empowering people to make positive choices for their health and to co-create their health. Just making sure that those choices are actually meaningful choices for people and that they have real choice in their life because of their social, economic and environmental conditions make healthy choices easier choices for people to make. So I'll finish off here with so how do we get this balance right between individual responsibility and social responsibility, between doing things on or to people, and we're doing a lot of that at the moment in response to the epidemic, and doing things with and for people, of forging ahead in the visionary way in which the English strategy does, and making sure we leave no one behind, because typically these strategies have improved health for the majority and left the worse off further behind. And how do we learn on past success by, how do we both build on past success, but also look to create new forms of success going forward? And I'm back to please discuss. The strategy is open for discussion at the moment. It's incumbent upon all of us to contribute to that process, and I'd certainly be encouraging everyone to do so. Thanks very much.
Thanks, Don. We have a number of questions. We'll stand 3/4 of a metre apart on this microphone each, and hope I can be heard. One of the things before we ask the questions, I just wanted to ask you, you've had unique experience in both government and in academia and public health institutions. What do you see as the barriers in getting the most scientific public health into government action here and
very good, very good. I'm not sure that there are big differences. I actually think that that governments in Australia and in the UK these days are far more mindful of the importance of using evidence as the basis for policy. Part of our challenge in public health, and more generally, I think, in health and medical research, is this issue of are we providing answers to questions that are useful? And I do think we have a challenge around this, that we are often providing, as I said earlier, perfect answers to a question that no one had asked. And applying scientific standards to research, applying scientific standards to research questions that are inappropriate, and not placing enough value on observational research, on natural experiments that are occurring in Australia and so on. So I think there's a real challenge there around what we mean by science, what the nature of evidence is in relation to public health, and how you marshal the best available information at the time it's needed. And again, another big issue there that ministers don't have the option of doing nothing. They have to take decisions and move on. They can't wait for the perfect answer. They have to act on the information that's available to them at the time they need it. And we've not got a great track record at marshalling the best available evidence at the time it's needed to make decisions. Again, some incredible lessons being learned through our experience with the pandemic that I hope will be transferred forward to our thinking about policy making in the future.
So very topically, one of the questions which I guess Julie Leask will address this afternoon from Christine McDonald is, how do we best combat the anti-science messages of anti-vaxxers and other powerful influences in our community?
Yeah. So first of all, we have to call them out. They're often based on completely bogus science, of course. But I made the point, and it's been my own experience in government, if you create space, then it will be filled by people who have a mission to divide and rule. And my sense is, in the example the example I spoke to earlier, and in the early days of our response to COVID, government were a little bit slow, in my view, in getting into the public space with their messaging. And it allowed every armchair epidemiologist and those who mean bad to fill the space. So for me, it's about being on the front foot at all times with the best possible information, most credible information. And we've a lot of experience of that we learned during HIV, and we've a lot more experience that we learned in the last 6 months. Don't leave the space. Make sure that credible information is available and accessible for the general public.
Popular question from Catherine North. One of the big barriers in the hospital setting is the lack of a funding stream to support prevention activities, often on a background budget deficits. Don't we all know that? How can we stimulate activity in the state-based hospital sector to drive prevention?
What a great question. I wish I had a really simple answer. I feel like I just want to join in with the complaint, but honestly, the work I've been doing over the last several years to try to demonstrate how more effective communication in the hospital setting delivers better outcomes for patients and actually means less pressure on the hospital system. There's increasingly good evidence to show that relatively modest structured interventions in the hospital setting, just the way we bring people into hospital and the way we discharge them from hospital, getting the communication right and better delivers far better outcomes for the patients and honestly reduces demand on the hospital system. Good evidence around that. We just need to marshal the evidence and make the point. But that's a very good question.
So a very quick last question.
Tony, up to your mouth.
Microphone.
Mic.
You've got the
Sorry.
mic.
No,
They can't hear you.
bit high? Okay. Yesterday we had it. Yeah. Thank you very much, Louise. So this is from Louise. The underlying goals are all important. The challenge seems to be that a focus on the best start is politically acceptable and great for paediatricians, but it means a focus away from broader upstream determinants. How do we maintain a focus on all goals? Can you answer that?
Of course, my simple answer to that is, of course, it's another excuse to focus attention both on the upstream and the downstream determinants of health, because what determines health in the first 2,000, drives health in the first 2,000 days, has as much to do with the environment, income, employment of the household, all of the underlying social factors of what's driving it. We don't address those, and we focus only on babies and children. As babies and children, we won't make the progress that we're looking for. It has to be both.